I realise I'm stepping on a few toes by standing up here in a minimally invasive meeting, suggesting that actually an open approach is the way forward. However, I think we can call it the mini open approach rather than anything else. So, getting it right first time is a statement that's being put around in the UK for the last few years, made by Tim Briggs, who's persuasive in various areas. Basically, with the footballers, professional footballers, you don't get a second chance. And we need the gold standard. And what I'm hoping to put forward today is the gold standard for the professional elite level footballer as a mini incision open rostrum. Now I realise that I'm surrounded by some very, very talented guys who can do some very, very talented surgery. Professor Takao has done some excellent surgery, minimally invasive with arthroscopic techniques. And basically, he's driving the Ferrari. It's sexy, it's fast, it's a really cool thing to do. Now, I've got this bloke, Mourinho, who may be breathing down my neck, and if I cock it up, if I don't get it absolutely right and I haven't got the evidence behind me, he will be pretty unhappy. This is my car. It's a bit boring, but over rugged terrain and extremely rugged terrain and things like this, that's exactly what I need. And I need it to be dependable and get up the hill. So the factors that we need to consider in a professional footballer are several. Is surgery actually necessary? What type of repair is necessary? And it's got to be reproducible and a low risk. So it is a common injury. In the 91 professional footballers in the English clubs over 2 seasons, 11% of all injuries. And there's a significant number of matches missed, which is a significant amount of money. But the evidence for operative treatment, it was quite sparse, and certainly Gino did this Cochrane database review back in 8 years ago now, and it suggested that actually functional treatment is the best way forwards. But we know that operative treatment leaves you with more stability. So how about the athletes? Because no Cochrane database review has done anything looking at the athletes. And what I'm talking about here is not your average simple ankle sprain. Okay, we're talking about severe ankle sprains with combination of both the ATFL and CFL rupture. So that's a significant one. That's not just a simple one. And the patient in this situation is a rugby player. He came in and he showed me his anterior draw. And I said, no, we don't tend to repair these. But he said, I don't care what you say, doc. This is not stable. And this was, he'd had it up and he'd had it iced, and it was 2 weeks later and he was doing his own anterior draw. And we know from Pinchberg that he suggested that the operative repair is the best option. And we know also that maybe a fifth, 1 in 5 patients will have instability later on. And we know that residual instability is predictor of ankle sprains. And a third of patients in playing Premiership rugby football will have a repeat sprain within 3 years, and 1 in 10 will have a repeat injury the same season. So it's a significant problem. Jordi was talking about microinstability. If you're putting forces through an unstable ankle, this is probably the cause for the footballer's ankle later on. And you've got a grossly unstable ankle, even if it's not giving way regularly. I think that we would now believe that that is causing significant problems later on in their career. We also know that intra-articular pathology is associated with these injuries, and even with peroneal tendon problems. Giovanni looked at this many, many years ago, which led to the AFAS statement back in Warsaw in 2011, suggesting that actually, if you look at the high-volume surgeons performing surgery on elite athletes, they're the ones that are getting the good results, and perhaps in the elite athlete, we should actually be performing an open repair early, or a ligamentous repair early. And that was then supported in the AIG group, who then wrote up this article back in 2013 with Stefan Guillot and Tom Abau in the AIG group. The concern that the football clubs have, however, is how long is the player going to be out? If you're going to operate on our player with a ligament injury, surely it's going to take longer to get them back playing. Well, actually no. If you look at conservative management, it's probably about 12 weeks for these combined big injuries to get them back playing. Operative treatment is about the same, or used to be. However, if you repair them, you can get them back early. That last 2 weeks, you can actually bring that forwards and you can accelerate their rehabilitation. And in fact, now it's down to about 9 weeks. I was told by a few of the clubs they've been pushing them on a little bit quicker, and we get them back now at about 9 weeks after an operative repair. Certainly it's no longer than conservative management. So what about the results of open surgery? Well, we know that you can get good results after 10 years, 24 or 30 professional athletes, and a 26-year follow-up, which isn't bad, 90% good or excellent results. There are some concerns. Open repair, Masato's had very good results with minimally invasive, with arthroscopic repair. There's perhaps an infection risk, perhaps there's some stiffness, but if you could repair it, you can push patients on very, very quickly. And I tend to get the patients moving their ankle from 1 week post-operatively to reduce the chance of getting stiffness. We also believe that we can do an anatomical repair. Mickey did some great dissections and some great presentations looking at the ligament and the accessory ligament coming around there. And actually you can get that ligament back into this where God had intended the ligament to be in the first place. So I believe you can get the true anatomical repair in these acute injuries. What about the arthroscopic repair results? Well, there are many techniques talked about. Stefan and Masato have talked about, have given good reports of it, but capsular shrinkage we know has a high recurrence rate, and there's Batista has reported good results in 22 patients with a 2-year follow-up. But at the moment, there's nothing there in the elite athlete that can support my practice treating the elite athletes, which is why I go for what I consider to be the gold standard. So is arthroscopic repair the answer? Now I'm going to get shot by our chairman here for this session. But infection and wound issues, yeah, okay, I get that. Professor Takao has talked about this, yeah, arthroscopic beats it hands down. Soft tissue dissection, actually I think we do less soft tissue dissection with the mini open approach. And I know that we can get a true anatomical reconstruction back on there again. Nerve damage, well, it's pretty low risk for doing that. And I think I can get the tensioning of the repair pretty well with the open approach. Evidence in elite athletes, and this is crucial for my practice, I think there's more evidence for elite athletes for the mini open incision than there is for the arthroscopic repair. What about evidence for open repair in elite athletes? Well, the problem we have in looking at all this data is, if you examine the journals, what is an elite athlete? What is an athlete? What sports they play? Is it a Premiership, Champions League, champion, whatever, Manchester City? A lot of the studies include 40-year-olds, 50-year-olds playing recreational football, and they're considered athletes. Some athletes are bowls players, and there's one paper in the American Journal that talks about gardening as an athletic sport, and they conclude a sport. I know, but they are not the same Premiership soccer players that I look after. So the systematic review that Mark Glazebrook's group has done with Chad, it's just about coming up in Issycos, has looked at the studies, and basically the conclusion is that at the moment, the systematic review of surgical treatments for chronic amputation suggests that the mini open incision rostrum repair is the gold standard. There are other techniques that are as good and will probably be better in the future, but they need to be proven that way, and we're not quite there yet, which is why I use it in the professionals. James White looked at 33 professional athletes from various different professional clubs, 22 isolated complete rupture of the ATFL and CFL, and there were another 11 that had associated injuries. And the question really is, what we've got here, is it actually happening in real practice? Well, the results of 2 years, all were stable and had a return to play. There were 2 superficial infections, which were treated with antibiotics. But basically, as you can see here, they returned to play at about 10 weeks on average. And I think this was published back in 2016, so this is 2014 data. We're now better than that, and I think we get them back at about 9 weeks. So in summary, I think the open rostrum gold gives a predictably good result. I don't think there's a proven advantage yet of treating these patients with arthroscopic repair. I think that will come, and I think that's going to come in the next probably 2 or 3 years. But at the moment it's not there, and I'd say I'm not quite good enough yet. I think in the acute situation we need to be selective, and we can consider an early repair in those patients that have had a severe ATFL and CFL rupture. And it enables return to play probably within 10 weeks. I think we need to force on and push on the early rehabilitation, and I think it reduces the risks of the long-term problems we see with chronically unstable ankles in the professional athlete. So in conclusion, athletes are different, and I think they need different treatment from Joe Bloggs with an ankle instability. And I think we do need to get it right the first time. When this bloke was breathing down my neck, he's a pretty unhappy chap most of the time, but particularly at the moment since he was sacked. I haven't seen him for a while. But yeah, it's cool. This guy, he's great. He drives great great cars. And I think that side of things is very, very sexy. Good luck to Stefan and Professor Takao for driving the fast car. But I'm afraid I'm still driving my Land Rover up and down hills because it seems to be dependable and it kind of works at the moment. But that's controversial. Masato, over to you. Thank you.
So, thank you very much. There are maybe 5 minutes for discussion. The first speaker talked about the elite the treatment of the elite athlete is different. So everybody is understand. So the first speaker shows the bone attachment is brings the early return. And the second speaker shows the open surgery of rostrum is also nice selection for the patient. So elite athlete. So do you have any question or comment to the yes, please.
I have one question, but for you, Masato, what is your treatment for sportsmen?
Oh, okay. Well, this is not my session, but for me, my treatment plan is all arthroscopic surgery. I'm sorry, James. Okay. So, but now I introduce your technique to my patients, especially for the big bone, subfibrillary patients. So it's very difficult to do in under arthroscopically. So in such patients, I introduce your technique.
One question more for James. What do you do if there is an associated lesion, like osteochondral lesion, post-traumatic osteochondral lesion, in your patient?
With a lateral ligament reconstruction. Yeah, I'll do exactly. I'll do this. I'll treat that at the same time. Often, if it's just a chondral lesion, I'll just take it out. I won't do a microfracture. I think in the acute situation, I will often just pull out the fragment and leave. I don't think you probably need to do a microfracture technique to the underlying because it's going to bleed anyway. So I'll just take it out and leave it. I do try and persuade them to take a little longer over the recovery. If it's on the medial side, I tell them I try and keep them protected weight bearing for a month. But and I try and stop them going back to playing football for 4 months, but there's a few pressures with that, and that doesn't always work. But I treat them both at the same time.
And you do that arthroscopically or with
so I'll do the arthroscopy first of all to get in there, and then I'll open it up, let all the fluid out. By which time it's all nicely swollen, and that's not perhaps an easy repair. And maybe this is why I think that I'll eventually be converted, a bit like when I used to do shoulder surgery. I don't do that because that doesn't work at all. But we do all arthroscopically, and I think that will come. I just need a bit more evidence. I need him to do more sportsmen to show me that I can do it.
And, do you add every time a good procedure?
Sorry?
Do you add a good procedure every time? Only rostrum or rostrum good?
No, only rostrum. Because of and I'm reassured, I've been doing that for years blind, And now Mickey has shown why that works, because we're hitching that up and it brings up the CFL. So unless the CFL has been, and on the scan, has come off the calcaneum, the os calcis, which is pretty unusual, then I will just hitch up the ATFL and that hitches up the CFL. So Mickey has reassured me that blind I'm doing it right. Well, thanks.
Thanks a lot.
Okay, Dr. Masato.
James, thank you for pointing out that select group of people. I think you're right. In that select group of people, we need to do something more than the traditional arthroscopic repair. My question is to the arthroscopist over there, Masato. Do you do in this high-level athlete? Okay, do you do your arthroscopic rostrum or your arthroscopic reconstruction?
It's a nice question, thank you very much. So it depends on the quality of the remnant. So I checked the quality of the remnant before surgery via the stress ultrasonography, and I checked it via the arthroscopic evaluation. So if there remains a bundle, good bundle, I do the repair technique, and if it's no bundle, so I move to the reconstruction. It depends on the quality of the remnant.
And James, do you ever do the reconstruction in this high-level athlete, or do you stick to the rostrum?
I stick to the rostrum. So far we've been lucky, I guess. But it's normally in the acute situation, even if we've had a few ankle sprains in the past, I've found there's been enough tissue to pull up. Now, okay, an isolated rostrum in a patient who's had recurrent instability, then yes, I will probably hitch up and do the Gould as well, routinely, pull something up there. But yeah, I don't tend to do a reconstruction. That's quite a lot of surgery for an athlete, I think.
So I have a question to Dr. Takao. So your technique, the bone fixation technique is very nice. So for the early returning to the sport. But I'm afraid some patients show the stiffness of induced flexion after study. Do you have any patient?
Thank you for the question. No, I don't have a stiffness. We are very careful with the position of the foot after at the end of the surgery. We believe in the physiological equinus, not full equinus or something like that, because if you left the foot with more equinus than normal, I think probably you go for some stiffness or difficult to react after the surgery.
Okay. Thank you. It's time to close this session. Thank you very much, everybody.
Thank you very much. Thank you. Yeah.